Welcome to the lecture on cultural competence. I say developing cultural competence because I don't think there is an endpoint in terms of the skills and the attitude that cultural competence entails. Developing, therefore, is in recognition that this is an ongoing process for health professionals and many others. So as a reminder, I'm going to revisit some of the main points made in the first lectures to situate this conversation about cultural safety in the context of the unit itself. Now, it was introduced in week 2 in the lecture Anthropology and Health, but you're coming at it now after many weeks of looking at case studies, looking at the social, cultural, historical factors influencing any particular health issue. So now when we get to this lecture on cultural competence, I suspect that you'll have a more sophisticated understanding of the social influences on health and illness. So the contemporary health challenges, it's worth remembering, are now increasingly global in scope. They're happening simultaneously in different parts of the world. It requires collaboration on a global right down to the local scale in order to address these changes. And the world is changing so quickly that it's difficult to keep up with some of the changes that are happening moment to moment. How this affects healthcare delivery is that many of us are living in pluralistic health systems, which means we've got multicultural societies, many different types of people living within a state, and the health systems being used are more than one type, more than one characteristic. So there's quite likely the biomedical model coexisting with some traditional forms of healthcare. The reason why this is important, of course, is because of the social determinants of health. Our access and control over the social determinants of health will influence whether or not we get sick, how severely, how quickly. Power is very important in terms of accessing healthcare. It affects our understanding of the issues. Do we have the information we need to make sense of this issue? Do we know what services are available? Do we know our options? Do we feel empowered to make decisions? And what resources are there to support us? Now, cultural competence or cultural safety is an important discourse because it draws attention to the fact that some people have far greater access and control over health than other people do. So let's go back and revisit how we defined culture in that second lecture. It was defined as learned accumulated experience, things that we took on over a long period of time that influence how we conduct every aspect of our lives. It is represented in both the material aspect, but also the ideational realm, the realm of ideas, values, attitudes, beliefs, way of understanding the health and illness. And so it is reflected there both in the material and the non-material aspects. Now, in this lecture, I emphasize the socially constructed aspect, the performed aspect of culture. Not that culture is the same as a group of people or a territory, but that it is a set of guidelines that people inherit that help us view the world, understand it, react to it, take in data from it. And therefore it is described as an inherited lens that we use to view the world. So therefore I was emphasizing that culture is not all the same within one particular group of people. Culture is not unchanging. In fact, it is always undergoing transition. Culture is not the same as race or ethnicity, and this is a particular pitfall that the cultural safety discourse can fall into. It is not necessarily synonymous with language, but language does powerfully influence culture. Culture is not necessarily the same as nationality. It is not the only or even the most important factor in ill health, and it is not just in patients. So these were some of the issues that I highlighted in the lecture on culture in week 2. What we need to carefully do is to differentiate between the notion of culture and the notion of race. And again, I put it in parentheses to explore the fact that social scientists find the biologically driven concept of race problematic. What is emphasized instead as of a social Darwinist point of view or a racial point of view, where the world is divided into distinct races, recognizable by phenotypic or external characteristics, and from that, using Charles Darwin's theory in an inaccurate application, says that you can rank these groups of people then from the most intelligent or the most civilized down to the most savage. people who are lacking in culture. Instead of this, we emphasize ethnicity, a shared cultural background, an identification with a group of people, being recognized, cultural background, your own perspective, with an applied sense of cultural superiority. I am better than you, and you look at their values, attitudes, beliefs, or practices and judge them negatively on the basis of your culture. Now, what's interesting is culture and race can often be used in place of the other, and in fact now in Europe, reactions to or criticisms of waves of immigration are now framed in cultural terms. We are culturally incompatible with these new migrants, rather than in racial terms like they used to be. The danger of all of this, of course, is perpetuating the cycle of prejudice, working from a very limited view of culture, the idea that people are culturally determined, somehow they're influenced completely by their culture at the expense of other factors, and that cultures are not changing, they're fixed to territories, and that everyone within them is the same. This can lead to overgeneralizations about people, and therefore stereotyping. All members of this culture, which they really mean a group, are like this, and therefore this is what I think of them. It is very easy to go along that cycle, therefore, into prejudice. You've got attitudes towards these people based on the stereotypes that you have created, into discrimination, which is the active acting out of prejudice against other people, and at the extreme form, this goes into persecution. So this is the cycle of prejudice. We try to break this cycle by starting at the point of culture. If we take apart this notion of culture, it is less easy for us to move into stereotyping or into generalizations, because we recognize not all people within that cultural group are the same, and that culture changes over time, and it is influenced by a number of different factors. So a lot of what this unit has been about really model as a culturally informed model of health. And we've drawn heavily in this unit from the social model, which is influenced as well from cultural attitudes. What do we place our view on? What do we emphasize as the important factors? Certainly I hope that you have seen that in the biomedical model, certain ideas are privileged over others. Way of talking, the priorities are different because of the cultural focus of that approach. So what happens when people have different understandings of health and well-being? So because of our cultural background, people do indeed have a different understanding of what it means to be well, what it means to heal, what causes a health issue, what are the most appropriate ways to treat health issues. Now, we have provided in this unit a critique of the biomedical model as a culturally informed set of practices and an institutional location and a way of thinking. But many people who come in to interact with the biomedical model, so to speak, have different ideas about health and wellness. They also have different expectations about which services are provided, when, where, why, and how. So as emerging health or social practitioners, it is critical that we understand the role of culture in the meanings that people make of their health, illness, and well-being. If you remember, we talked about the biomedical model as a triangle, which shows some of the power that is there. Because this is the dominant model of health in many Western societies, it has high value, high prestige. It is supported by the government, by the powerful force of law, by sympathetic publications and journals, for money for research. And at this pinnacle, you can think that at the top where power is concentrated is the greatest amount of knowledge about how the system works. At the bottom, where power is most diffuse, there is the least amount of knowledge about how the system operates, and how people who understand what is happening. Because of this, medical experts, and I include yourselves in that, hold a lot of power in relation to patients who come into this system. And within that, there's a hierarchy so that they have varying levels of power within the biomedical system itself. Now, if you recall to the lecture, an earlier lecture, we looked at Aboriginal definitions of health, here in the context of Canada and Australia. Now, interestingly, Canadian Aboriginal peoples have picked up the World Health Organization definition of health. Here it says, health is a state of complete physical, mental, and social well-being, and not merely the absence of disease and infirmity. So it is not just physical disease, but also an overall state of well-being that goes beyond the physical body, beyond the biomedical, into, if you like, the social model of health. The Ottawa Charter took this a bit further. Health is not possible without peace, shelter, education, food, income, and a healthy and sustainable physical environment, social justice, and equity. A medical healthcare system alone cannot maintain health. So here they are drawing deliberate attention to the social determinants of health and naming some social determinants that are particularly important for achieving a healthy life. In Australia, the definition here is Aboriginal health means not just the physical well-being of an individual, but refers to the social, emotional, and cultural well-being of the whole community. So here we have some different factors being emphasized. Emotional health, cultural well-being, and it's not just of an individual, but very clearly of the whole community, in which each individual is able to achieve their full potential as a human being, thereby bringing about the total well-being of their community. So the individual and the community are seen as in relationship, a symbiotic relationship. And another factor comes in here. It is a whole-of-life view and includes the cyclical concept of life, death, life. So it is not just right now for one particular individual. It is in relation to a very complex understanding of time, and in relation to wider groups of people than just the individual, and in relation to more than just the physical body. If you come into the biomedical system with this view of health, working from either of the definitions I've provided here, you're going to find that you have very different values, attitudes, and beliefs, and therefore expectations about caring. So, in many ways, you could say that Aboriginal approaches to health, both in the Canadian and in the Australian context, emphasize more than just the physical health, which we see in biomedicine. It also includes environmental, spiritual, mental, emotional, cultural, and I would actually add social as well. The biomedical system is not meant to deal with all of these different aspects. It hasn't been set up to be. It is not within the inherited lens, if you like, of the biomedical model to consider all these different factors. Therefore, what can happen for people when they encounter the biomedical model is culture shock. This is a definition taken from a great book, Benangunj, Bridging Cultures in Aboriginal Health. Here, a definition of culture shock is the tension and anxiety combined with feelings of isolation, sensations of loss, confusion, and powerlessness associated with entering a new culture. They use a medical metaphor, interestingly, for this: incubation, crisis, recovery, and full recovery. So the idea is that you have unpleasant feelings that are evoked when you encounter a new culture. Now, I have said that culture isn't necessarily a group of people, it isn't necessarily a territory, it isn't necessarily a language. So when you're encountering a new culture, even this phrasing seems to create culture as something that you could somehow identify and shake hands with. But even though that is not the way it works, we know very clearly when we enter a cultural milieu, if you like, or a field of operation that is not similar to our own. And it can be incredibly shocking. So some of the symptoms of culture shock are provided here: longing for family, loss of identity, dissatisfaction, impatient, a feeling of inadequacy, insecurity, embarrassment. One of the main things is you've lost all your tips, all your cues as to how to act. So you may not know where exactly you should position yourself in relation to other social actors. What should you say? How should you move your body? Where do you get information? A lot of this can be thrown completely out of whack. And some of the signs of culture shock, therefore, are listed on the right. A whole series of behaviors that change the way you interact with the world, the way you understand yourself, which can be extremely disruptive. The reason why it is disruptive is that we take in a lot of information through verbal and non-verbal cues. And this orients us, if you like, in space to understand how we should behave. Verbal language, of course, you may find when you enter into a hospital, you come into the biomedical sphere, if you like, that people speak differently to you. They may speak more quickly, or more slowly. They may use slang terms such as ticker for your heart. A lot of people don't know that a ticker, like a watch, refers to the heartbeat. And so if they talk about your ticker, we're going to check your ticker. Someone might say, I don't know if I have a ticker. Where is it? Response to questions. Biomedicine relies on a very direct questioning style. This is not always comfortable for people. The style of questioning, asking questions that are taboo, can be very upsetting for people. So these are some of the overt or visible verbal cues that are provided. But even more powerful is nonverbal communication, the way your body presents itself, the level of eye contact, the length of eye contact, the distance put between two different bodies while interacting. Extremely powerful influence on communication. But then you get into a whole series of rules and conventions about how you interact, what is important, what is prioritized, and then etiquette down to acceptable behavior. All of these areas can be different for different groups. And so you can see that entering into a hospital, if you like, the bastion of the biomedical establishment, is like entering a foreign land where all of these cues are no longer as easily available. You could argue that there are three cultures at play in this particular context. If a person enters into hospital and begins to talk to a nurse, you have the nurse with their own background, individual, ethnic, cultural, gender, social, historical, etc. Then you have the professional culture of nursing, which carries with it its own values, attitudes, and beliefs. And then you have the patient's cultural background, which may not, of course, be one, but be drawn on by several. And then you've got the culture of the institution or the place within which this takes place in a hospital. So you have a lot of discourses that are being drawn on in one particular interaction. Now, earlier I gave you some examples of cases where cultural safety, if you like, would have been helpful. Here you've got a clash or an inconsistency between traditional beliefs and biomedical beliefs. Now, the first example, if you cast your mind back, was about the Hmong people. They are a hill tribal people from Laos, originally from China. Many of them came to Australia as refugees from Thailand. Now, this case study was a story of Mai, a 35-year-old mother of 6 who was in, she had a cesarean section due to the positioning of the baby. Following the C-section, she had poor health, and she could not explain necessarily why, because physically she was recovering from the C-section. However, she believed that during the operation, because she was put under a general anesthetic and moved from the operating theater into recovery room, one of her 3 souls got lost in the process and couldn't find its way back to her body, and that was why she experienced ill health. In this case, the hospital allowed a shaman to come in and a soul recalling ceremony to take place, both in the operating theater and in the recovery room, so the shaman could call back the spirit of this woman. It involved incense and a live chicken and some chanting. It took about 15 to 20 minutes. Following this soul recalling ceremony, Mai's health improved immediately. She believed that it did indeed bring back one of her 3 souls that was missing into her body, and health was restored. In this case, it was interesting that the hospital in Melbourne was very willing to negotiate and to have in the spiritual leader of the Hmong people in order to help this woman recover her health. Another example, this is also drawn from the Hmong community. A Hmong woman arrives at hospital with severe lower abdominal pain. The diagnosis is she has a ruptured ectopic pregnancy or a ruptured ovarian cyst. They confirm, yes, that it's a ectopic pregnancy, so it's in one of the tubes, and an operation is recommended. They tell the woman that one of the tubes will need to be tied and cut. Now, she's worried about this because she believes that one of the tubes brings boy babies and one of the tubes brings girl babies. Boy babies in her culture are very valued. She's worried, what if they cut the boy tube and she can only therefore have girls afterwards? The medical staff said, well, we don't know which one is the boy tube or the girl tube, but she may bleed to death if she does not have the operation. A Hmong doctor is consulted. They discuss the mandate of life, how long she has to live, and her destiny is to have a son. In the end, she agrees to have the surgery, but the result is she has 3 daughters. So her interpretation of what happened here is they did indeed cut the boy tube, and she was left with a girl tube, and a cost culturally and emotionally because she was not able to produce a male heir or a boy child. Now, the third case study comes from the United States. A Vietnamese father visits an emergency department of a large metropolitan hospital. His son has a fever and is very unwell. The boy is assessed, and staff notice severe bruising on his shoulder and upper arms consist with abuse. Here's a picture here, and you can see the striping on his body. The father is taken into another room to be questioned. His language is poor. An interpreter is eventually called. It has been suggested to him that he has been harming his son. Instead, it transpires that he has been using coin rubbing techniques to reduce his son's fever. So here is the photo here. So there are unknown markings on the child's body. Based on their mandate with regard to social services, healthcare professionals thought this may be a pattern of bruising consistent with abuse, and therefore was going to get involved in social services. Communicating with the man, turns out that no, it was not a case of abuse in the father's eyes. He was using a healing technique with which the medical practitioners were not familiar. Again, this could go in 2 very different directions. What is important in this case is the dialogue between the parents and the healthcare professionals. What is your understanding of health? What is going on here? Let's talk about your son's health. So in these 3 case studies, it is clear that having a dialogue between the patients and the healthcare professionals would avoid very unpleasant situations, may increase client compliance, if you go for that term, with the medical treatment, and certainly results in more respectful healthcare. So the term cultural safety was developed in Aotearoa, New Zealand in the 1980s, and it acknowledges the impact of colonization on health outcomes for Maori. Now, Maori are the indigenous people of New Zealand, and again, this is out of recognition that the healthcare system reflects the dominant values of the dominant group, which is not the Maori. It also recognizes the power imbalance between culturally diverse patients and healthcare providers. What they emphasize in terms of cultural safety in New Zealand is shared respect, shared meaning, shared knowledge and experience of learning, living, and working together, and truly listening. Again, truly listening. In the 3 case studies, what was important was hearing from the patient how they understood their own health. So the cultural safety principles as developed in New Zealand encourage healthcare professionals to be self-reflective. Look at yourself and understand what you bring to any healthcare interaction. Seek to minimize power differentials between yourself and your patient. This may mean to stop using complicated jargon, to slow down a little bit and to sit and to talk to them. Perhaps even to position yourself physically so that you don't communicate the power differentials. Most importantly, talk to people and listen to them. Try to understand their worldview. Undertake a process of decolonization, which means recognize the impact of the past on contemporary healthcare arrangements, interactions, and outcomes. Finally, ensure that you do not demean or disempower others through your actions. The idea was that you would move from cultural awareness, which is just a general understanding the fact that people have different ways of understanding things, right through to cultural sensitivity. How does this awareness influence my behavior? How could I accommodate cultural needs that are different from my own? And then move towards cultural safety. How do we know when we are becoming culturally safe or culturally competent? The difficult thing is we can only really know that by asking our patients, did they feel culturally safe when working with us? So let's look at one case study here, is pain. Pain is one of the most commonly cited reasons for people seeking healthcare. And it is a culturally informed experience, both the original sensation, how you understand that, and then how you respond to that. So the responses to pain, or if you like, the language of distress, are associated with individual variations and cultural factors. Different cultures think different behaviors are appropriate. Some, for example, what is associated with the stiff upper lip of British people and some Eastern European groups emphasize stoicism, not communicating pain. Other groups emphasize pain behavior. They encourage you to be vocal, to use your arms or your facial expression to communicate the pain. And so therefore, pain behavior is influenced partly by individual characteristics and by social attitudes towards pain and the expression of pain. So a culturally competent response to this is to understand, first of all, familiarize yourself with cultural variations and in the language of distress, and remember that expressions of pain can be culturally patterned. Therefore, you will not automatically assume that the person screaming in one bed and the person being completely quiet in the other do not necessarily have the same level of pain. Recognize that verbal communication about pain is imprecise. There's a number of words we can use to describe pain, and also nonverbal responses are communicated differently by different people. Avoid judging or implying stereotypes. Asians are less likely to complain about pain, for example. Well, Asians is a huge group full of diverse people, individuals, diverse cultural outlooks. So avoid the checklist mentality. Ultimately, each case should be assessed individually with compassion and empathy, trying to view it from the insider's point of view. So behind this idea of cultural safety are some ideas that we've used in the unit full stop. One of them is social construction. We create socially the way we see things, the way we understand them, and therefore the way we organize them. Experiences are always inevitably given meaning and therefore understood and experienced through cultural and social processes. Again, this is why our access to health is very much caught up with the exercise of power. And now a discourse is a way in which we are able to speak, think, and act about an issue. This is drawing from Michel Foucault. It is a set of ideas or a framework for thinking about a topic that will influence how a topic is spoken about and the actions that result from such thought and language. Now we have a few discourses here in this lecture that are overlapping. One is the discourse of biomedicine, the way we think about, understand, create, manage this whole issue of disease from a biomedical point of view. Another discourse is that of cultural safety, coming and saying, yes, but this needs to be done in a way that is supportive of a person's cultural background. Now, what's happened is that this idea, therefore, cultural safety as a concept originated in Aotearoa, New Zealand, but then it transported and changed slightly when it came to Australia. In Australia, the term cultural security has been used much more, and the emphasis is slightly different. This is partly because, whereas in Aotearoa, New Zealand, there was a treaty in 1840 between the colonizing power and the indigenous group, the Maori, which provides some basis for negotiating access to healthcare and really the rights of peoples in relation to the government in New Zealand. Australia has a very different history, and Aboriginal peoples, diverse though they are, have a different history than Maori people do. What is happening with the term here? I do notice that security is a very interesting term which changes slightly the meaning of this concept. But it has also moved to the United States, where it is referred to as cultural competence. Europe has yet to really decide, will it be competence, security, safety? What understanding of this term will be there? And elsewhere as well. Many countries around the world are dealing with multicultural populations, multi-ethnic, multilinguistic, and they are also dealing with pluralistic healthcare systems where biomedicine and traditional beliefs, or a number of traditional beliefs, coexist in one location. It will be interesting to see over the next years how this concept of cultural safety itself will grow and change in different contexts. I see these different applications of the term cultural safety as having different goals, which of course are not mutually exclusive. The first one is an outcome or instrumentalist focus. We need to use cultural safety in order to achieve And here, this comes from the National Center of Cultural Competence in Washington, and this I see is a very instrumentalist view. You want to use this notion to make definite change in your, what do we have here? To respond to current and projected demographic changes. In other words, the people coming into hospitals are different than they used to, and we need to respond to them. To eliminate long-standing disparities in health status. It is recognized that a variety of minority groups have inferior health compared to the dominant group in societies such as the United States, Australia, Canada, and New Zealand. To improve services and outcomes. To meet legislative, regulatory, and accreditation mandates, because now it is a requirement that health professionals appropriately look after all sectors of the population, to gain a competitive edge in the marketplace, to decrease the likelihood of liability or malpractice claims. That is the view in the United States in terms of the focus of why we need to be culturally safe. A second one, which I think is a bit dangerous but also hard to avoid, is the checklist focus. And this idea is that you've got one particular group and therefore they've got these characteristics of that group. So it is a list of practices or attitudes of beliefs mixed in with a cultural group or an ethnic group, and therefore if you behave in certain ways you have met your obligations for cultural safety or cultural competence in these areas. There may be tips to read behavior and words. For example, some textbooks will have a section at the back talking about different religions and the views of disease within those, different ethnic groups and some of the beliefs there. Now, it is suggested, usually what happens is this brings with it a suggested number of, a list of behaviors, recommended behaviors for healthcare professionals. Now the benefit of this, if you are dealing with one particular group over time, it is very beneficial to get to know some of the cultural views of people within that group so you understand why perhaps things could be happening. But again, to caution, we know that cultures are not internally consistent. There are individual variations, group variations, variations over time. Culture is not fixed, it is always changing. And so therefore this checklist focus can become a bit dangerous if we don't take those other ideas into account. The most effective way, which I think draws on the other ways, is to see cultural safety as a process. This is emphasizing the interaction. This acknowledges there are no easy rules to follow. I wish there were, but there aren't. And so therefore, what you need to do is recognize diversity within social groups, within your own social group, within your profession. Where this approach is good, I think, is it emphasizes the quality of interaction, how it is when two people or more come together to talk about health. And it works on the notion that culture is both in the healthcare professional and the patient and the context. And therefore there's an acknowledgement at the very start about what is going on here. One of the key skills that you need in order to do this effectively is critical thinking. Critical thinking in its simplest involves asking why. What is going on? It involves reflecting on our own social position. Where do I come from? What is happening here? What is the context in which this takes place? Questioning the evidence with which we are presented, trying to slow down that quick loop around the cycle of prejudice by stopping and saying, wait a minute, where did I get this information? What's the source of the information? What do I think about this? Being open to possibilities for change, being open that there are different ways of seeing things. Quoting Peterson here, the focus is on power relations between groups and between individuals, and on the inequalities that arise from the exercise of power. It draws attention to the power of knowledge to define others and therefore to control them, and spells out what this means for health. In this unit, we've drawn on the sociological imagination template. You could say originated by sociologist C. Wright Mills, but also developed by Willis. So the strength of this template is both to apply it to yourself. What historical, structural, cultural factors and critical moments in my life has made me the person I am today? What colors the view that the inherited lens that I wear with which I view the world? But then also to be aware that every single other person that you interact with, colleagues, clients or patients, family, has their own complex combination of factors like this template influencing their behavior. And then again, you're interacting within a particular context at the time. This knowledge alone, not necessarily knowing what specific details impact the person in front of you, but a true awareness of the fact that there are such complex and overlapping factors in any healthcare situation, it's humbling. It means that you can't know everything. It undermines your expert status. It reinforces the complexity of what's going on, and therefore emphasizes the need to talk to people. How do you understand what's happening? Where are you coming from, in other words, mentally, spiritually, or emotionally? So the implications for professional practice. The first thing is empathy. Developing the ability to be able to walk a mile or even to put on the shoes of another person is a core characteristic. Suspending judgment, trying to put aside or at least be aware of some of the images, stereotypes, and preconceptions of the cultural other that we have. And sometimes these are very unconscious. Being tolerant of ambiguity. Sometimes there is more than one way to understand a particular situation, and it's not easy to reconcile the two. Sometimes living with that is a challenge, but that's what sometimes is called for. Resolving conflict, trying to learn from conflict and not seeing it necessarily as always a bad thing. Working in partnership with your clients, your patients, with other healthcare providers. This is a list that is suggested by Eckerman and others. So, ways of engaging people. You may come in with some more general questions to ask people. What do you think caused your problem? Why do you think it started when it did? What do you think your sickness does to you? How does it work? These are some questions to bring out people's understanding of where they're at, what's going on in their bodies, their spirits, their souls, their lives, their families, their communities, and therefore what is the best way to intervene and work with that person to create a good health outcome. Thank you for listening.